Welcome, those of you who are joining. I'm just going to give another minute for people to join because I see these numbers going up. Just give another minute or two. Okay, so we'll get started. So welcome to our webinar, which actually this is really going to be an interactive meeting. And so I'm really pleased today. What we're going to do is that we have two perinatal substance abuse experts. And both are actually from MCPAP for Moms. And what we're going to talk about today, and the focus in general, is going to be how perinatal psychiatry access programs are addressing substance use disorders. You can go to the next slide, please. So just some, want to do the housekeeping, Dee? And then I'll introduce.
Sure. Good afternoon, everybody. Thank you for joining us. Just some quick housekeeping slides. We are recording this meeting and can make it available upon request. If you've not noticed, all participants do enter the meeting muted with their webcam off. Just in case you're calling in over the phone, please enter your meeting ID number, and now there's passwords required for our Zoom. One thing we ask is if you could please keep yourself muted during the presentation part of the meeting. Next slide. And once the presentation part is over, we will be opening it up to Q&A, conversation, and discussion. So if you want to participate when you're ready, you can turn your webcam on and unmute yourself to be called upon, or if you prefer, you can use the chat box. We do prefer that if you are speaking, it's great if you can turn your webcam on, but we won't kick you out if you don't. And if you do have technical difficulties, you can email me, the organizer, at deirdre.logan@umassmed.edu, or send us a message using the chat box. And thank you, everyone.
Thank you, Dee. So what we'll be talking about today, as I mentioned, is substance use disorders and I'm pleased to introduce Gina Kelleher and Lena Mittal from MCPAP for Moms. And they'll be talking about how perinatal psychiatry access programs can integrate content for substance use disorders into trainings, consultations, and resource and referrals, and also engaging key collaborators in the substance use disorder community. And also substance use disorder programmatic challenges and solutions will also be discussed. So what's going to happen is Lena and Gina will do a brief background, and they'll give about 10 minutes of an informal discussion about what MCPAP for Moms has been doing and all initiatives around substance use disorders, which Lena has been leading, and Gina joined, how long ago was it now, Gina, that you joined MCPAP for Moms?
Nearly a year ago.
I was going to say a year. Okay, that's what I was going to say. It felt like about a year. Gina joined about a year ago and has really been, both are doing an amazing job at MCPAP for Moms addressing substance use disorders. And so Gina's role at MCPAP for Moms is she's our substance use disorder project manager for MCPAP for Moms. She has a master's in counseling psychology from UMass Boston, level 1 licensed drug and alcohol counselor, and has 25 years of experience providing direct treatment to individuals with substance use needs. She's also managed various SUD programs, and including acute detoxes and many other different settings. And no, Lena, Gina, I can speak from personal experience, has really been a real asset to MCPAP for Moms, has a huge, diverse and deep experience in substance use disorders, and has really been critical to all these projects. And then Lena Mittal, who is a perinatal psychiatrist and the associate medical director of MCPAP for Moms, and really partly became the medical director because of her expertise in substance use disorders. And a lot of what her, when she came to MCPAP for Moms, was specifically around addressing substance use disorders. She is at Brigham and Women's, where she's the director of the Division of Women's Mental Health there. She's, as I mentioned, a perinatal psychiatrist, but she's also boarded in adult psychiatry, consultation liaison psychiatry, and more recently also addiction medicine. So brings a ton of clinical expertise and especially addressing substance use disorders among pregnant and postpartum women. As I mentioned, has been the leader of the substance use initiatives at MCPAP for Moms, and so we're really excited to have them here today. And they'll give a brief overview of what MCPAP for Moms has been doing, and then really open it up, because we also want to hear from other states. I know, just seeing the names of who's here today, I know there's other states who are doing a lot of substance use disorders. So as always, this is really to both, present what one program's doing, but also learn from all the other programs and have an interactive discussion. So So please go ahead, Lena, and I think Gina's going to go after Lena.
Thank you, Nancy, and thank you for the invitation in particular, and for this opportunity to really kind of tell you a little bit about what we've been doing at MCPAP for Moms. So our kind of initial effort to engage around the substance use disorder world really kind of came from the fact that we were sort of inherently seeing that as we were kind of engaging in the work around broadly, first depression and then broadly kind of more just mental health in general for perinatal women, and we were hearing from providers, there was just this sort of very clear and growing discussion around comorbidity. And as we were seeing this was also paralleled with the sort of increasing impact of the opioid epidemic as we were kind of going forward through, this was around 2016 through 2017. And there were also these other efforts happening throughout the state through other larger bodies. So our state chapter of ACOG, and there were other kind of efforts happening. So it all kind of, there was this confluence of forces and factors. And we have this kind of wonderful opportunity to work closely with all of these sort of champions around these topics. And so we had, with MCPAP for Moms sort of already having been in existence for a few years, we had the opportunity to really leverage the relationships that we'd already had to make a request to the legislature for additional funding. And so as we were able to get what we call the SUD expansion, that's sort of just what we referred to this effort, we had this kind of idea of really expanding the purview of MCPAP for Moms, but also expanding broadly the definition of mental health to include substance use disorders. Because I think historically, psychiatry and the substance use disorder world have lived a little bit split or siloed, and then furthermore split from the rest of the medical world, so especially obstetrics and pediatrics and primary care, despite the fact that our patients actually live amongst all these roles as whole humans and don't have their different aspects of their mental health split off into these different categories. And our goal was ultimately to broadly increase broadly expand the definition of mental health. And so what we were sort of able to do was, think a little bit about, once we were able to successfully expand our funding to be able to grow our program, we kind of used the model that we had used for depression and sort of paralleled that for substance use disorder. And so it was creating materials, doing educational programming, and also bringing on a project manager. And so that's where we were really lucky to find Gina Kelleher, who joined our team about a year ago. But the sort of goal and effort of hiring somebody into this position took quite some time to sort of develop a brand new position and to develop a program in which that person could have to put a stamp on sort of this new effort. And what we really did in that first period of 6 months or a year after the expansion was to think a little bit about who are we trying to engage. And we have had long-standing relationships with obstetricians, pediatricians, primary care providers, and psychiatric providers, prescribing providers, who were seeing women with psychiatric and substance use comorbidity. And so we already had some relationship with these provider groups, but there was a whole other provider group who were seeing and working with women with who were perinatal and had psychiatric and substance use comorbidity, and these were substance use treatment providers. And so as we were exploring who may have the greatest impact or who would be potentially interfacing with these patients, we really started to think about that these are going to be provider groups with different needs. And so as Gina joined, and she'll tell you a bit more about how we kind of approached the outreach necessary to figure out these different needs, we really had to kind of think about a sort of two-pronged approach where we utilized the existing model and relationship and reputation that MCPAP for Moms had already, where we were highly trusted and highly regarded by the OB community. They were already calling us and engaging with us for educational materials, educational programming, and consultation requests. And so we could utilize and that as a springboard to say, hey, we also can help with this other large topic that may be something that you didn't know you could call us about before. And so that was sort of one approach, but to really make our way into a whole new provider group that we hadn't really interfaced with was a large piece of work. And that was something where bringing somebody like Gina on, who had a long career and a lot of expertise amongst this provider community, really helped us make our way into an entirely new provider group. And so I'm going to segue that over to Gina now to tell us a little bit about how we did that, because she's been really, really key to that progression.
Thank you, Lena. So yeah, so I guess the challenge when I was hired was to figure how to get the word out about MCPAP for moms throughout Massachusetts in the most efficient way possible. So we learned that there were different level of care providers meetings. Level of care being in the SUD world could be acute treatment services like detox, CSS, which is clinical stabilization, outpatient, residential. So all of those level of care type programs would have these regular meetings where they all got together, discussed policies and different updates. So what we did is we invited ourselves, or we asked, could we show up for a half an hour and just talk a little bit about MCPAP for moms, and bring you some materials, and we'll tell you about our services, and we'll tell you how to access those services. And I will tell you very few programs I heard about MCPAP for moms. So I realized that it's going to be repeating the information over and over and over again until it's in their brains and that there's saturation, right? About what is MCPAP for moms. So what I found is sometimes I would show up on my own. Sometimes it was Lena and myself. It's always better to have a psychiatrist with you, and especially a perinatal psychiatrist, because these SUD programs rarely connect with psychiatrists. They just don't. So they really appreciate having an expert in the room that they can learn from and also ask questions to. What we also found is when we brought materials, they would gravitate toward the same materials. There were materials on easily accessible materials, say on mental health. So for example, you know, what is the difference between baby blues and perinatal depression or perinatal psychiatry? And they would snap that up. Or assessing risk for harming baby. Because, you know, you see there was a lot of anxiety. There was a lot of anxiety in this population. Population meaning SUD providers and programs. They really know SUD. They're not as comfortable with mental health, and they certainly have a little more difficulty getting support for their patients, perinatal patients with co-occurring disorders. So the other thing we found is once we connected with SUD programs, even just a call or an email, I would offer a training, and I would offer kind of like a menu of trainings saying, you know, it could be on psychopharmacology and perinatal populations. It could be on cannabis and in pregnant and breastfeeding women, things like that, as psychopharm I had mentioned, or co-occurring disorders. And I said those trainings can be designed based on the audience type, whatever your needs are. And they snapped that up. It's very common in SUD programs to have lots and lots of trainings because there's constant needs for CEUs, but they particularly were very thirsty for this information. So it was a great carrot to engage SUD programs and get the word out about our services, and also to spread knowledge. The way we, you know, Lena had definitely had some contact with stakeholders, and I had some contacts through my other my past history working in the field. So the big ones in Massachusetts are the BSAS, which is the Bureau of Substance Addiction Services, and then the Institute of Health and Recovery, which is IHR. They work very closely together to fund and oversee most of all the SUD treatment programs for, sorry about that, I'll just mute my. Sorry about the joys of working from home. So we made sure that we were at all those meetings with stakeholders. We were at the table, both literally and figuratively, just so they can see us and remember we are here to help, and this is how we can help. I, as a substance use disorder professional, I looked at the materials and the website, and in the beginning the website definitely looked very, this isn't for us, this is for OBs, maybe a little bit more OB centric or pediatrician centric. So we went in and it wasn't like massive changes, but we made it more inclusive so that it would appeal to substance use providers and programs. So just even changing the language to say women with mental health and or substance use issues. We just found that everywhere and changed it. We put a tab in for substance use providers and programs. The other thing, some of these are very practical things that we changed and that were requested by substance use disorder programs. They have in general fewer resources than probably than what we were used to working with. So it's a faster pace, they have smaller spaces, they have less to work with. So they also wanted to help get the word out. And so they requested a one-page flyer. And so on this one-page flyer, and we can certainly share this with you later, we put down what the resources were, how to access it, a list of trainings that we could do, and that also that it could be modifiable for depending on the program. We also, when we went around and met with key stakeholders in these programs, we definitely did a needs assessment to identify gaps, and we can talk more about that. Some folks that we're still trying to reach, women who are incarcerated and women who have been sectioned. In Massachusetts, it's called Section 35. And so we're trying to reach that core population just to hopefully expand their capacity to work with this population. And I'll stop there and you can ask more as we get into the more interactive section.
And I just want to add one thing, because Gina is too modest, I think, probably to say this, but I think one of the key pieces about this expansion is that I don't think we would have had the same ability to reach out to treatment programs without somebody who has the background in addiction treatment that Gina has had. And so I think that's one of the lessons that we learned along the way, and I think that's been really impactful in terms of moving our outreach forward. And perhaps that might be something that could be helpful to others in thinking about if you're trying to engage more with the substance use treatment provider, is to really provider community, is to think about engaging someone who specifically has an LADC or who has training and experience working in that space.
Thank you, Lena and Gina, and I would agree whenever, I would just agree with all of those comments you just said, Lena. Yeah, so if people want to ask questions, we have some questions that we can moderate discussion. If people have questions for Lena and Gina, please go ahead and ask. You can either unmute and ask a question directly, or you can type it into the chat box if you prefer to do it that way. So please go ahead and ask questions. Does anybody have a question right now for Lena or Gina? I have a question. So one of the questions that I remember when MCPAP4Moms was starting all this, and one of the goals I remember kind of becoming clear as we thought about this is that there was sort of 3 goals, especially I'm thinking about the HRSA programs that are a lot of their goals. So they're required to address substance use disorders as part of one of their deliverables to HRSA. part of it's they're required to have OB practice screen for substance use disorders. So I remember when we first started kind of, and please add, this is the goals I remember ahead, but I'm curious to hear your thoughts because you may remember otherwise, was there was kind of one goal was like educating OBs around substance use disorders, which when I first started, I was like, that's what we're doing because we help OBs. But then I realized actually there's this whole other SUD world, which you just spoke about, that's really important. And I personally hadn't thought about that in the beginning as much. And then the other thing that became clear was educating, as you just talked about, substance use disorder providers regarding how to address substance use disorders during the perinatal time period and also how to address comorbid psychiatric illness. And then one of the things I saw happen that it was one of our psychiatrists have gotten calls about is that we've gotten a lot of calls from people, for example, a primary care provider or family medicine provider who's going and seeing women in a group home who are living in a group home for women in recovery, and they're calling asking about the patient's psychiatric illness. And women are often experiencing significant psychiatric symptoms, don't necessarily have access, and often this person who's going to do these visits at the group home and seeing these women are managing pretty complicated psychiatric illness. So those were kind of the three things that occurred to me, and I'm particularly curious to hear about around the OBs and around thinking about screening and helping them implement screening, because I know that's one of the things that the HRSA programs have a deliverable for. And please add to those kind of goals that I remembered and clarify them as needed.
So I think one of the challenges in the very beginning was really trying to parse out the goal of screening, especially for substance use treatment, because as we had sort of, the footprint we had left behind was that with depression treatment, our goal was to engage providers in screening so that they could then initiate treatment for relatively uncomplicated cases, especially. That was one of our goals. And it's a slightly different, I think, it became a little clearer as we went along that wasn't necessarily exactly the same goal with substance use disorders, because it's a different ask of the OB provider to engage in substance use treatment. So we certainly would be there to support OB providers who might be interested in prescribing buprenorphine, for example, for the treatment of opioid use disorder, but prescribing buprenorphine does not feel as accessible as prescribing an SSRI, for example. And so I think that was something that really we had to think a bit about when we were thinking about what are we asking for when we're asking providers to screen. The other part was when we first started doing this, there was very little evidence base to help us decide about which screening tools were the best. There were a few out there that none of which were sort of clearly better or more effective or easier to implement. And so that was something we kind of grappled with in the beginning too. And we ultimately chose as a program to suggest the use of the NIDA modified assist quick, it's like the TAPS portion of the NIDA quick screen. And so that with some modifications to include cannabis essentially. And so we went with that because it felt like a tool that could most parallel in terms of the process and workflow, the EPDS that we had, our Edinburgh postnatal depression scale that we had already been interacting with and our OB community was already so comfortable with. And I don't think we could have done any of the SUD screening promotion without having had the depression screening that they had already implemented and accepted so well as a provider community. So I would say like that's kind of the way I think about the screening. I don't know if that addresses your question, Nancy, but I feel like there was a lot to kind of just thinking about how do we engage the provider group in another screening task when we had to figure out what are we going to do with that screen.
Mm-hmm. Yeah, and yes, no, that does answer my question. I think that's one of the challenges, and especially when it's also in addition to depression and anxiety and like all these other the other things. Does anyone have questions for Lena or Gina about that, or anyone want to enter in the chat box? And you mentioned, Lena. Oh, we have a question here. Okay, what would you recommend programs in states with newly legalized or soon to be legalized recreational cannabis do? This is a great question. Do to prepare based on what you've seen in Mass? It's a really good question.
Yeah. So, Gina, you can speak to this too, but I'll say that you know, one of the things that became so clear is as Gina was kind of interfacing with all different types of SUD treatment providers, and as we were kind of interfacing with OB providers, we would hear over and over again this question, like, how do you do a risk-benefit analysis when people are using cannabis to manage mental health symptoms, to manage nausea and vomiting of pregnancy? How do we think about, in Massachusetts, we actually had this kind of, I think in a way, complicating sort of progression where cannabis was first legalized as medical marijuana first, and then for recreational use. And so I think that created a myth that it was in fact a treatment, you know, and I think with relatively limited evidence base for medicalized use. And I think that was a challenge that we sort of faced. I do think that this is something that everybody feels really uncomfortable with. And I think, Gina, you can speak to this, but this was like every single treatment program that Gina would speak to, she'd say, and can you please throw in at least a few slides about cannabis? Every single one wanted to talk about this because it's not straightforward. The evidence isn't straightforward. The conversations aren't straightforward. And people really grapple with the risk-benefit conversations. And I don't know, Gina, if you have other thoughts about.
Yeah, I mean, just my experience working in, say, a bridge clinic where, you know, there's a constant threat with overdose and with fentanyl and just really high risk substances. You know, the culture is in SUD programs is not to be too worried about cannabis use. It's not even kind of on their radar sometimes as an issue. However, you know, if you then think about how, you know, the rate of unplanned pregnancies, I don't think there's a lot of information about the risks of cannabis use in pregnancy and in breastfeeding. So we identify that as a gap or as a needs that at the very least in all our trainings to make sure that that information is being conveyed. And then also to have a conversation about why is this substance being used? What are the benefits? Is it for nausea? Is it for anxiety? Are there other ways that you can handle that? Are there other ways that we can address that are lower risk? So hopefully that answers your question. But that's the approach in the SUD world. And then I think there's maybe a slightly different approach in the OB world. It's similar, there's some overlap, but it may not be as prevalent, but it's certainly higher than it was.
Mm-hmm. Yeah, I remember getting calls in the beginning of like when from OB saying the patient got a medical marijuana card for her PTSD. Is that right? And I'd be like, okay, well, let's talk about that. Like they had no idea. So those are the kind of calls we would get. They're really complicated. Or we have another question in the chat box here. Did you experience concerns about substance use screening? This is a good question. Did you experience concerns about substance use screenings and mandated reporting requirements? And how do you address this? And yes, we certainly have, but go ahead, Lena and Gina, please.
Yeah, I think it's really, really important to know what are the nuances in your state, because the nuances in our state have even evolved over the past like 3 or 4 years, given, you know, changes in legislation, federal legislation, and then also policies within our state. So the way our state has addressed this is by rolling out a program called Plan of Safe Care, which many, many states have, in which there's this kind of goal of looking at identifying risk and identifying strengths and trying to enlist a conversation, a needs assessment kind of conversation with each woman who's identified to be at risk for a substance exposed newborn, and create a plan to figure out what are the types of resources that could be added to her care to enhance her ability to parent. That's kind of the like larger goal of the Plan of Safe Care. Many states have plans of safe care programs, and they're monitored in different ways. The way ours is monitored and tracked is through our Department of Children and Families, which is our child welfare agency. And so this kind of complicates matters because the sort of strengths-based reporting, the strengths-based needs assessment is tied to mandated reporting, which really confounds the efficacy of this, because many women experience mandated reporting in a very punitive, traumatic way, understandably. And so it can be very hard to ally with a woman who you're trying to engage in treatment, but also at the same time saying, you know, while you're engaging in treatment, we're also going to report you to child welfare agency. And so this has been really complicated in Massachusetts, but not every state is structured in the same way. So we have had lots of concerns because I think when especially OB providers are calling and saying, you know, either they had not, the patient had been unaware that the legislation is, the shorthand term for it is a 51A is the name of the report, that a 51A would be filed at the time of birth. And I'm told that this was filed in the hospital and she's very upset and I didn't know this was going to happen and she didn't know this was going to happen. It's incredibly traumatic and it can create this huge rupture in the relationship and a huge disruption for a woman and her relationship with her baby, and can be such a blow that can really impact her sobriety. And so, you know, we were kind of grappling with how do you, you know, continue to support an OB provider and support that patient when there's this huge rupture, but at the same time, it was a system we have. You know, this is the way, this is a requirement that this is the way that the legislation is interpreted in our state. So we've had to figure out how to kind of preemptively work with with providers who call us to make sure that as prophylactically as we can, we're trying to like engage the providers and having these conversations with patients as early as possible, and trying to engage with also in parallel LI with our DCF agency to improve their evidence-based practices and to be a resource for consultation for their social workers who there are, you know, ways in which they feel very uncertain in how to proceed with these complex cases. So we've tried to address it from a variety of angles, but it is a really sticky challenge. And Gina, I think you might have some other thoughts about this too.
Well, it was interesting because, you know, I actually reached out to DCF, the Department of Children and Families, recently about that question, going, you know, if a woman tests positive for marijuana, now that it's legal, is it a 51A? Are they supposed to file a 51A? And they couldn't answer. It's actually not black and white. It's really confusing. And I think it comes down to judgment. And just around that same time, somebody called us to try and find a therapist for a woman where a 51A had been filed on her because during labor and delivery, or right before or after, she tested positive. And I probed a little bit and I said, can you tell me why you filed this? Why did the doctor file this? And they said, because she tested positive the whole way along. And they had, you know, they were concerned because there was no maybe change in the behavior. So they kind of had to make that call, but it's not always black and white. I don't know if that helps.
I had a patient who was positive for marijuana. She was using it only for the nausea, and this generated a CPS report, even though it was only a small amount during her pregnancy. So they are just still doing it.
What state are you in?
North Carolina. Yeah. And she received involuntary services for the children, and then they remain involved for quite some time. Yeah. Thank you.
Yeah, I think Gina might be frozen. I think Gina might be frozen there, unless she's keeping that expression. I think something happened with Gina's screen there. Yeah, thank you for sharing that, Carolina. I think that's challenging. I don't know if you have anything else you wanted to add. I think hopefully we'll get Gina back here. I'm pretty sure she lost her, or she got her internet connection went down.
I'm here. Yeah.
Yeah. No, I think. Oh yeah, Gina, she'll come back. Well, can you maybe? I think, do I have her cell phone number? She'll come back, I'm sure. So we had a couple more questions, but thank you for sharing that, Carolina. And I think that is a frustrating. It's yeah. And I think that's not uncommon. And so we have a couple more questions in the chat box. So Wendy Davis from PSI asked, when you consult with providers, do you share, this is a good question for Gina, hopefully she comes back soon, but you could answer, Lena, I'm sure as well. Do you share with them referral sources for specialized substance use disorder, patient education, treatment, or support? And actually,
yeah, and Gina is just texting me that she lost her connection. She's trying to get back in.
Yeah,
so
I figured. I'm sure that's what happened.
But one of the great things about having Gina on the team, or having someone in the position specifically focused on cultivating relationships with the SUD treatment provider community, as well as educating and kind of facilitating internally our own training, is that she's been a resource for our resource and referral specialists and all of us in terms of the resource and referral services that we can provide. So if we have a case where the substance use treatment, Gina's back too, so
Sorry about that. Yeah.
We have a case in which a provider calls and the woman needs substance use disorder specific resources. Any of us can consult with Gina, and we're able to take advantage of the fact that she has this really specialized knowledge. And we also have this, when we're presenting and when we're engaging and reaching out to the SUD treatment community, we can say, please, Gina will give them her card and be able to say, or, now less exchange of cards, but please contact me directly. I can be a resource directly. If you have questions, you're not sure if this is something that we can help with, just contact me. And so it's really created this way in which we're able to both develop relationships with some of the treatment providers who can then also be resources when we need to do resource and referral, but also gives us a good sense of what's going on in the treatment world, so that we can be, all of our resource and referral specialists are able to have a good sense, or consult with Gina and she can work on that part of it. So Gina, it's the question about whether we provide specialized SUD patient education, treatment, or support when providers consult with us.
Yeah, so you said it exactly. If it's, we've different kind of services. Sometimes it's finding therapists. We can certainly do that. If it's patient contact, they come to me.
Oh, she lost her connection again. I think she lost her connection again. Okay. Gina will come back again. We're having
technical. I reach out to them and I find out exactly what they need. So,
Gina, you cut out for a second there.
I was going to go into another room and see. Sorry about that.
Yeah, I didn't hear it. Can you just repeat those last 2 sentences?
So yeah, if it's a patient contact, I can reach out directly to the patient and have a conversation about what they need, and kind of, just create a list or curate a list based on what their needs. A particular woman comes to mind where she said, I want both a support group, like a virtual support group, and I want a therapist. And so we're kind of able to use an interface and use their location and use their insurance and come up with something that works for them.
Mm-hmm. Yeah, I remember I had it was a psychiatric nurse practitioner, psychiatrist call that was working at a inpatient psychiatric inpatient substance use facility, and the patient was had a cocaine use disorder and was asking about resources specific to that, and I was like, I'm not sure. So I called up Gina and was like, Gina, what can we offer? Like, it was a really, really specific question, and that happened a couple of years into this expansion, because I think year one we never would have gotten a call like that, but obviously their outreach had helped, and we're getting calls that are super specific now. So, and the other thing I'll add is that in a similar way that we can call with Gina, like in the beginning, our psychiatrists weren't comfortable treating substance use disorders, and people said, it's not our expertise, what do we do? And Gina would say, you're gonna know more than the person calling, which reassured us. But also we can all call Lena, and I've called Lena several times when I've had cases and, and just ran it by here, and I often will, I'm not board certified in addiction. It hasn't been it's not my subspecialty. So, and we often discuss them in our case consults as well, because it's not like all of our perinatal psychiatrists aren't necessarily, and one of the other things we did was we all got certified certified too as well to prescribe Subutex. So that was the other thing we did, because in the beginning we needed to increase our own internal capacity too. So when we talked about Gina being the specialist there, Lena has also been kind of the person that we've leaned on for that expertise, which has been really helpful. And we have another question. So Wendy Davis is coming, all states need more Ginas and Lenas. I would agree with that. But I'm happy to keep them in Massachusetts, but yes. Although I wouldn't want them, anyway, yes, but I would agree with that. And then so Amanda Haynes from Florida has a question here. I came in a bit late. They say, did the guests address success in OB or behavioral health practices in implementing expert screenings into their workflow? Lena, you touched on that a little bit earlier. I had kind of asked about it, but I think, I'm not sure if we totally answered that question. So you may have some additional comments there. So I think that is it is a challenge.
Yeah, it's definitely a challenge. The one kind of fortuitous thing is that we weren't the only ones having to think about this. And so this was there were all these parallel processes and folks kind of putting some thinking into this. ACOG had also been working on practice guidelines around this. Our local Perinatal Quality Collaborative had been using resources to implement SBIRT and to do training across the state. And so we were able to essentially just try to create a resonant message with all of these other groups. And so one of the things that we did, because we had already a very, I think a really well utilized toolkit that addressed depression and other mental health conditions. And so we created some materials to incorporate into that essentially modeled substance use screening, modeled the depression screening sort of workflow that we'd already sort of worked out as an algorithm. And we chose a screening tool, the NIDA Quick Screen Modified Assist, the TAPS portion of it, as a tool. And then we do have, and we can distribute this, I suspect, through the network, and it's also, you can find it on our website. It's essentially a risk stratification model that follows SBIRT. So the screening first, and then an assessment that goes, if there's a positive screen or any kind of level of concern, some follow-up questions that we outline for providers, and then using the answers, a risk stratification model that then has different outcomes. None of those outcomes necessarily require that the provider initiate treatment, which is a little bit different than the depression workflow, which I think is the biggest distinction with the substance use treatment kind of screening workflow that we were suggesting. And so that's always the challenge, is kind of, we're always going to be limited a little bit by the availability of resources outside of our system, but that was sort of the way we kind of modeled it, which is a little bit kind of hinged in timing and in practice to the depression screening workflow, but it's with the outcomes being slightly different. And we can distribute those materials, or you can go to the MCPAP4Moms website and it's all available as PDFs.
Mm-hmm. Yeah, no, the SUD toolkit, it's yes, that's something definitely everyone can take a look at that. It's available, and as Lena mentioned earlier, we used the TAPS was the screening tool that was recommended. So Barbara Sheehy from California has another question in the chat box, and okay, Mandela says thank you. Amanda says thank you, Lena. So can you? So Barbara Sheehy is asking, can you share the logistics of how you handle incoming calls to MCPAP4Moms and questions regarding maternal mental health, substance use disorders, or both? So they're sort of asking about how do we handle calls for both resource and referral around substance use disorders, and then also around telephone consultations. Like, what's the pathway for those?
I'm happy to speak about that because I'm on the phones 1 day a week. And is the connection okay? Okay.
Great. Great.
Great. All right. All right. So it's very similar to any request for, say, therapy for a woman who has either a history of depression or anxiety, or has a high EPDS, result. And so it's very similar. A nurse will call in or leave a message, usually if it's resource and referral, saying, I have a patient, they'll leave their name, their date of birth, their location, their insurance, and they'll give us 1 or 2 clinical on what's going on. Usually it's quite general, but sometimes, they could say this woman is experiencing OCD. Can you find somebody who has some experience working with obsessive compulsive disorder. Or they could say, you know, this woman is 5 years in recovery from opiate use disorder. She's been struggling a little bit with cannabis use. She's okay, you know, but can you find her a therapist? So we'll look for somebody. We have this great database we work off. And so I'll personally try and find somebody with letters like an LADC afterwards and a licensed mental health counselor. So there's both. They have the experience of addressing both substance use and mental health. If it's a consultation, it's the same thing. They'll call in and, you know, often it's a little bit more often that it's more active use rather than past use. The number one substances actually we get calls for are opioids, then cannabis, then alcohol in that order. But also benzos would be included in that. And so it usually is something complicated when it's a consult. So somebody maybe is actively using, they're struggling, maybe there's issues with father of baby, domestic violence, and it can be, you know, how do I manage? What would you suggest for next steps for this woman? And then there'll be a consultation, and then after that, it usually turns into what's called a patient contact to set them up with services. And if there's substance use, I'll reach out to them and kind of get a sense for like what they need. And hopefully that will answer your question.
Mm-hmm. Thank you, Gina. Lena, do you want to speak to the flow for the psychiatrist? So like if there's a consultation and they're calling about, often it's both, but if they're calling about specifically like a mental health versus a substance use disorder, for the psychiatry, like telephone consultation, face-to-face workflow.
Yeah, I mean, I think that we have a really like collaborative group of psychiatrists who I think also have put in a fair amount of effort to get comfortable. As Nancy mentioned, we all did the waiver training to become comfortable with the nuances of buprenorphine in pregnancy, but also just buprenorphine in general. We do a lot of kind of internal capacity building around substance use issues so that people are more comfortable addressing phone consultations during their shifts. But we also have the ability, we have meetings where we can address cases where, you know, I wasn't sure what to say, what would you all have done? We have a lot of case discussion about sort of just to make sure we're checking our body of knowledge. And then it's very reasonable. I think most of the providers I've spoken with, if there has been a point where we're not totally sure what to do in that moment, and I want to consult with a colleague, providers are usually very understanding. So there may be moments where we come up with a plan, a tentative plan, and we'll say, you know, let me just consult with a colleague and I can get back to you if there are components that we're not totally clear about. So if somebody needs to consult with me because I have maybe a specific knowledge around the substance use disorder world or treatment or, you know, medications, we do have that sort of ability and that kind of exchange. And so I'd say like that'd be the only thing. I mean, I think for the most part, our psychiatrists are pretty facile, and no matter what, I think we still have such a much more comfort with substance use treatment than the average OB, pediatrician, or primary care provider, that we're able to really help them, even if we don't necessarily feel we're optimally expert. And I think that's a huge value added.
Yeah. And yeah, I agree. And I think in the beginning, we considered, well, do we have everyone just talk to Lena? Because like when our psychiatrist really didn't feel comfortable, we thought about, I mean, I think that question was arise because people were uncomfortable. And I think we thought, well, we're just going to train everybody up because we want as a program for everybody. And I think that initial, you know, that initial anxiety around kind of us addressing it was passed with knowing we had Lena's expertise. And so that was kind of how we did that. But we did think about that, but we decided we all need to be able to do this, and we'll learn by actually providing a consultation. And I think developing the toolkit was helpful too, because we all worked with Lena Toolkit, we all reviewed it, and then we could all use the toolkit. I think the process of developing that and developing the trainings kind of also got people built our internal capacity too. Okay, and then there's another question from John Strauss in Massachusetts. Could Gina speak more about how eager the substance use disorder providers were to speak with perinatal mental health resources because they know SUD, but not enough about mental health? Also, they were not aware of how to use the EPDS. Oh, you're on mute, Gina.
Just as OBs may not be as comfortable thinking or working or treating a woman with substance use disorders, you don't really see that in substance use programs. They're okay. They're comfortable with that. It's the mental health part that's tricky. In particular, any medication other than an SSRI. So for example, women with bipolar disorders or on mood stabilizers or on antipsychotics, that's where you see the fear, right? Where they want to learn more about this. And then there's all this, you know, there's myths out there about postpartum depression. Like, what is it? Is it only the postpartum depression, or is there a postpartum anxiety and kind of harm to baby? I think that's what I'm hearing. Like, how do we handle this? Like, and in SUD programs, a lot of times, if there's any question of danger to baby or depression or anxiety in a pregnant or postpartum woman, they're kind of referred out. But sometimes that can be very difficult. It can be very difficult to find psychiatric prescribers. So that's why I think there was this, John, there was a real eagerness to hear this information and actually have a psychiatrist in the room where, you know, that can answer some questions, some tricky questions, quite honestly, very tricky questions. Lena will attest to that. And there was I don't think they'd ever heard of the EPDS. I certainly hadn't until I started working and doing a little research on MCPAP for Moms. They do their own type of intake, a biopsychosocial intake, but they didn't use these screenings. You know, it's just not really common. There's just a huge intake process where there's kind of a general assessment. Is somebody depressed or they're feeling anxious, and kind of rating that. And then from that, like, what do you do? And again, there's nothing specific, as far as I'm aware, to pregnant or postpartum women.
Yeah, and I know everyone's we keep talking about Gina and Lena. So because not all states have a Gina and Lena, as pointed out earlier. So one of the things you could think about, though, knowing that I know sometimes they're like, well, it's great, it works in Massachusetts, but how do we do it when, you know, we don't have some of those resources, or Gina and Lena in this case? So, you know, you could think about hiring one thing to consider is having, it doesn't have to be someone like Lena. We were fortunate that Lena happened to be one of our psychiatrists. She had the expertise. We're like, we'll do an SUD expansion. It worked. But another option would be you could hire a part-time consultant to be on your team. So, it's unusual to have a perinatal psychiatrist who also has an SUD expertise. Like, that is definitely, that's a gem that we have here. But there are, you know, other substance use specialists, for example, you know, often they're trained in internal medicine that can kind of fill in some of those gaps, and that could be available to consult with your team or build capacity, just to think about if you're in a state that doesn't have that, because some states don't have a lot of psychiatrists. They certainly don't have perinatal psychiatrists. Forget about one who specializes in substance use disorders. So that can be really hard. But there's other ways to go about that, because, you know, a lot of places may have a substance use expert, but they don't have to necessarily. And as you mentioned, Gina, they're often comfortable with pregnancy and postpartum. So that part they could help build your internal team's capacity on as needed. So I just wanted to add that too. So it makes it feel feasible for all of you, and, you know, and for those of you in other states. Any other, I know we're just running out of time. Are there any other questions? Or I'm also curious to hear if anyone has anything to share about things they've been doing in your states. I know, for example, that I think Maryland's on. I know that they have a substance use. Oh, I see Kelly's just opening up her camera. I was just thinking of you, Kelly, thinking that I would love to hear an overview of what you're doing in Maryland.
Hi, Nancy. Yeah, we, as you know, had really hoped to fund a BHIP for moms, is what we're calling it, in the hope that we get it. So in 2012, we launched our Child Psychiatry Access Program and have really yearned for a program for moms. We weren't able to do that, but we really have a lot of buy-in across the state. And what we did was, in 2017, we got buy-in from our Department of Health to launch a substance use access program. So we now have MACS, Maryland Addiction Consultation Service. So we've had great success in engaging providers around the state. Thank you, Sarah. Some member of my team is on. So there's our website. So for 3 years, we've been providing consultation to prescribers across the state. Initially, it was just for opioid use disorder, but we've expanded to any substance use disorder, and also chronic pain management. So we've been doing that, and we do take calls for pregnant women, although it's not our main focus. But we worked with the Maryland Medicaid and got funding through the MOMS grant that came out through the Center for Medicaid in this last year. So we'll start our work in January, and we'll have a Max for Moms that's launching. So we've been doing the pre-work and working with them on the needs assessment. So we've been looking for ways to make lemonade and engage our state partners. So we're excited to be launching that in January officially, but our focus has really been on thinking about how we expand the number of providers in Maryland. So through Max and through Max for Moms, we'll be working to get folks waivered. So we're currently running monthly waiver trainings virtually. So we're really thinking about how do we expand our workforce. And then we offer what we affectionately call BUP 101 and BUP 102 training. So we really work with folks to think about kind of what are the barriers, what does it mean to be prescribing buprenorphine, and then we'll do a follow-up that we call a BUP 102. We give it better names, and we work with core service agencies or health department folks to think about what their either region or their county needs to really engage folks and think what are the barriers to treatment. So a lot of folks we find get their waivers and they don't use them. So we also will provide in-office technical assistance. So we'll come out and figure out like what does it take to get you to go from prescribing for one person maybe to 2 people, get that up to 6 people. So usually we'll do that in person, but right now it's video or phone. And we're excited to be expanding that work to really be focusing on working with pregnant or postpartum women. So we are in the planning phase, but we'll be getting out our really specific outreach material to be working with midwives and lactation consultants and taking that up a notch. We just had a Dr. Welsh, who I think you met, Nancy, when you came down, did a webinar specific to treating pregnant women with opioid addiction. And we had like 200 people engaged and join us online. So we're hoping that we're going to have a strong engagement, but yeah, we will be specifically launching Max for Moms in January.
We want to hear from you. Okay.
Chris Welsh was my mentor in medical school. It warms my heart to hear about him again. So
yeah, so you know he's really passionate about this work. So Chris, and then I'm sure you know Eric Weintraub, Lena. Yeah, so Eric's the PI on our Max project, and they're both consultants on Max and have been, as you know, real advocates and champions across the state.
Thank you, Kelly. I saw you were on, and I'm glad you shared. And also, people posted a couple other websites there. And yeah, Kelly, we'd love to have you at another webinar. We can have you share it. I also hear Miriam Music just posted that, wish we had time for her to speak about this more, but we'll have to do that on another meeting, that in collaboration, it looks like they have one in Michigan in collaboration with their Michigan Opioid Collaborative. Their MC3 Perinatal has, it sounds like an opioid collaborative as well. So would love to hear more about the other meetings, because I know we really have 3 minutes, so we'll have to wrap up. But thank you, Gina and Lena. We'll just have some closing slides here with some updates. Please tell us how we did, fill out our survey too. And thank you everyone for all your questions and for all the sharing. So just to give you a few updates about upcoming meetings. So our monthly convenings, we sometimes these are webinars, sometimes they're more interactive meetings like that. We're calling them convenings because they're kind of, I know that you guys like that. We've heard pretty consistent feedback. The network likes it to be interactive rather than kind of always in a webinar format. So so the next one's going to be, we're still having them on the second Tuesday of the month. The one in October, on October 13th, is going to be a special one focused on equity. This is at a special time. It's 2 hours, because what we're going to do here is it's going to be an interactive, experiential meeting or interactive webinar led by we engaged some consultants who are from Change Matrix, who are working with the network around equity. And also, so the goal of this is really to help you both have experiential experiences yourselves and help you all think about how all of your access programs can help promote equity and be and as you go through your work, doing it with an equity lens. So, and for that meeting, there's a couple of things. So it is 2 hours because we just felt like that couldn't be done in an hour. It really felt like it needed that time. So we hope that you'll all be able to take the time to do that. And it will, that will prepare us for the summit, which I think is on the next slide, but that's going to be focused on equity. I'll come back to that. And for the webinar, just a couple of things. We're going to ask that everybody do 2 implicit association tests before the webinar, because the goal for this is that you've done a little bit of work beforehand, so you go into it kind of with this little bit of work beforehand. So that will be one of the expectations. There'll be more details to come. We'll send you the links for that. And also, when you come, it's going to be interactive, and you'll be doing some people will be doing their own work during it. So come with a pen and a paper, and the goal will be that you'll be writing some things down, and also that you have a computer for the meeting. A tablet would work fine, but it's not something where you can it might be hard to call in because it will be something that's quite interactive. And then the next meeting after that will be December 8th. And then we have at the usual time. And then our virtual summit, again, the focus of that is going to be equity. And really the goal is that October 13th is sort of a prelude to the summit. And we'll really build the foundational sort of experiential experiences and also knowledge and introspective thinking that would lay the foundation for the summit. So really hoping that, you can come to that meeting on, I believe, if I remember the date correctly, it was October 13th. And that way, and we think you'll get a lot, yes, October 13th, you'll get a lot more out of the summit if you're able to come to that one October 13th. Of course, if you can't, you're still welcome to come to the summit, but we think that the summit will be, you'll get even more out of it if you're able to come to the one on October 13th, because the summit really builds on that October 13th meeting. So we will be in touch with more details. Again, please fill out the survey. We appreciate that. And thank you, Gina and Lena, for coming and presenting, and everyone for coming today. Hope everyone's well. Thank you.
Bye-bye.
Bye.